way will go. That weight is 19.5, so that's 3 points. In the last week, she's decreased. Last 2 weeks, she's decreased, so she gets 4 points there. She's actually taking normal food, but less than normal amounts, so she gets 1 point there. Her performance status is she's not feeling up to most things, but is in better cheer less than half a day. And so she gets 2 points there. But if you see, most of her score is from this box. She has no appetite, she's got nausea, things taste funny, and again, with gynecologic cancers, a lot of times they'll say it tastes metallic. It's usually from the metallic spoons and forks, it's not necessarily the food, so using plastic spoons and forks can help that. She has vomiting and fatigue. What if this was a 0 here, this was a 0 here, and this was a 0 here, but she had 9 points here? Reality is in another month, all of these things are going to be going down. So this point score here is the most important thing. The intervening is the most important impact that you can have to actually show you risks and how you can intervene. So she's got 16 points, just like the older man. And in reality, a lot of physicians will look at her and say, she's overweight, she's got plenty of reserve. In fact, it would probably do her some good to lose some weight. This woman has reserve if she's going to the North Pole. That's about the only thing her reserve will help with. None of us have reserves of lean tissue. Everything that we have is serving a purpose, and none of it can be lost without having implications. So let's go to this person. The reason she has a black line here is to say the difference between the above the waist and below the waist, in case I hadn't covered it, but we already have. Now, if you were to, I've asked people, just looking at this one, is there anything that would tell you that maybe she's got some good things going on? Interestingly, I had someone once say, well, she's got jewelry on, she must be taking some care of herself, so maybe the jewelry means something. It's a good pickup on her part. She's got what looks like probably an ileostomy. It's functional. She doesn't look to be obstructed. So basically that would say probably her GI tract is working to some degree. She has a central line up here. Let's say that that's parenteral nutrition. Okay? The thing that's most important here is she's got what looks like was previously a very large abdominal wound. Could have been a radiation burn, could have been a surgery wound that has closed up on its own over a period of time. And so you've got this kind of grayish stippled thing, and all you have left to heal is this little black area down here. Could this woman have healed a large abdominal wound if she wasn't anabolic? That's probably the thing that tells you more than anything else that she's probably in a different stage than the other two. So, her current weight is 105. A month ago she weighed 100 pounds. Last 2 weeks, nothing's decreased. She gets 0 points for box 1. She's taking only 2 feeds and or nutrition by vein, so she's getting completely meeting her requirements by vein. Interestingly, we'll say, since this is a slide I've been using for years and years and years, used to be that we didn't cycle TPN, or parenteral nutrition. We just gave it 24 hours a day. Do you think anybody had any appetite? No. So we'll say that she has no appetite, but all of her other symptoms are good. Now, this is where I come to truth. This is not my patient. I can't tell you what her performance status was. My name is Faith. It's very hard to lie. Okay? The reality is, though, one of the women who is like this, when I first met her, she had 3 kids. She had been diagnosed with a low-lying rectal cancer right after the birth of her 3rd child. Basically, and there were multiple bad things that happened after that, including the diagnosis of her colon cancer, her low-lying rectal cancer, an anastomotic breakdown, recurrence, a whole lot of things. When I first met her, she was 5'4" like this woman, but she weighed 65 pounds. And she'd been on home TPN for 4 months by clearly somebody who didn't know what they were doing. But the bottom line is we got her back to her relatively normal weight, but normal weight. Couldn't get her above 100 pounds though until we put her on exercise. Had her see physical therapists, and almost immediately she started putting muscle mass on and gaining weight that was above her kind of low normal weight. What's interesting is she raised 3 boys. She would make Thanksgiving dinner for everybody else. She everybody. She had basically a fairly normal performance status. So again, she gets only 1 point there. So I think this can show you how, again, depending on whether somebody is becoming catabolic and going down, or is anabolic and is now changing and coming back, it really can make a big difference. And that's physiologically what's most important in this case. The ongoing evolution, again, Gabrielson was the first who actually did some validation of the aspects of the short form or the abbreviated abridged form, and looking at that. And she actually did basically look at different sensitivities in terms of cutoff points and compared it to the MST. But what's interesting is she actually did a rock analysis, and here's the PG-SGA, the one that goes almost to the corner is the full PG-SGA, and here is the PG-SGA short form. Again, saying what we all knew was the case, and that is that there's very good correlation, very good agreement between the two in terms of their scoring. So our Rodriguez paper I talked to before about the 10 points associated with depth. Again, this is that rock analysis. This was only using, this was using the full PG-SGA, looking at hospitalization, looking at sensitivity and specificity. What was interesting is it showed an impact in terms of survival, regardless of whether you were looking at advanced disease or you were looking at early disease, which says that same correlation and the impact of nutrition is independent of the degree of advancement of the cancer. That's a really important one. I think if all of you have one article to read about the PG-SGA and have conversations with your physicians, this is probably one. The other thing that it showed, it didn't matter what kind of gynecologic cancer. It could be cervical cancer, ovarian cancer, uterine cancer. It really is consistent across. So again, we had this great idea of greater than 9 was critical need. You can't get much more critical than death. So people are taking this tool, and I'm sure people in Portugal are going to be taking this tool and expanding what we know about the impact of this and the impact, importantly, in terms of intervention. So basically the PG-SGA, I think the key take-home message, it's a 4-in-1 instrument. It's a proactive risk assessment, can be used as a screening tool. You can do it for nutritional assessment. You can look at it to see what do we need to do in terms of interventional triage. Importantly, it can be a way of monitoring outcomes and monitoring intervention. If you guys see a patient, you give them some ideas, you put a feeding tube in, you put them on parenteral nutrition, how these numbers change help you to document that in fact what you've done is making a difference. Importantly for the patients, their weight may not change rapidly. If it took them 6 months to lose 40 pounds, it's going to take them a while to get it back. But if you can say, you were losing a pound or 2 a week before you came to see me, and we've been seeing each other now for 3 weeks, you're 6 pounds heavier than you would have been if we hadn't talked. That gives them something to focus on. The fact that their PG-SGA score is getting better gives them something. So the more we can do to let them know they're improving is a very positive thing. Across the board, in many of the data publications that we haven't talked about, but certainly again if you look at the bibliography that's included here in your package, across the board, high sensitivity and specificity. Predictive of both adverse and improved clinical outcomes. Some of the slides that we didn't show you today but that are in your handout really address, there's one in terms of pancreatic cancer, in terms of parenteral nutrition with and without, nutritional intervention with low calorie and high calorie with no treatment of pancreatic cancer, but that those who were taking in high calorie actually doubled, short survival, but doubled their survival based on that. Time-consuming aspects, as I said, 80 to 90% of that time is completed by the patient. They're really helping you streamline your patient care so you can make a difference. For the time that you're talking, the time that you're spending with them and their family is really the highest quality time that it can be. It empowers and increases the awareness of both the patients, their carers, and professionals. It's easy to use, and certainly with adequate training for the physical exam, even if it's the sneaky physical exam, but more some of the other things that we'll talk about later, is very easy to use. Again, as I've mentioned, it streamlines and focuses the clinical process and time to optimize both the quality of the time that you're spending and hopefully the outcomes. No one does anything, and I think I started this out with, I never thought 20 years ago or 22 years ago where we'd end up being. I would have never known that this would be my second trip to Portugal. I would never have known there would have been a Portuguese translation with a website translated, as well as having a number of people who have approached us now in terms of research using the validated cross-cultural adapted, I should say cross-culturally adapted, being validated instrument at this point. These were some of the major key 9601 sites. I certainly have international collaborators. When I first did this slide, it was Australia, Canada, Netherlands. I now should include Portugal. We've also got people in Thailand, China, etc. We've really got a truly global translation and research group, particularly Harriet Yeager-Whitner, who you will get to know very well, and her, so this is now kind of like the fourth generation we're getting into. Basically, Martine is her PhD student, and the reality is I feel like I'm getting to know the world through the PG-SGA, and I think you're going to get to know your patients in a better way through the PG-SGA. This was a man, I said, almost everything that we do for our patients is to get them to the milestones that they want to take part of in their life. And I was giving a talk, I was flying up to the Mayo Clinic in Rochester, Minnesota, I think it was last November. And I sat down next to a man, a young guy, but he had what looked like a radical neck dissection. Now, I'm a surgeon, so I notice these things. But I can't be sitting next to a guy and say, oh, looks like you had a radical neck dissection. What's the story? And that is not the way you open up a good conversation. So I just thought, he looks awfully young to have had that, but we'll just leave it alone, we'll sit and talk. And so we talked for about the next hour. And then he finally said, so what are you going up to Rochester for? I said, I'm giving a talk on nutrition and cancer at the Mayo Clinic. Oh, that's really interesting. I had a tongue cancer with flora of the mouth, and see, I had a radical neck dissection. You wait long enough, the patients will always give you the information. I said, oh, well, that's really interesting. Where did you have your treatment? Oh, MD Anderson. I said, that's a very good place in Texas. Since I obviously think nutrition is very important and you look pretty good, did you have a feeding tube? Kind of puts his head down. He said, no, I'm a guy. I said, okay. He said, I told him I could tough it out. I did not want that feeding tube. I would be fine without it. I would make it happen. I said, okay. You're kind of making it sound like it didn't work so well. He said, no. He said, it was the middle of summer. I hadn't really had anything to drink or eat in over a week. But I was getting crazy staying in the house. So I went out to do the lawnmower, to cut my grass. And I passed out while I was there. I was dehydrated. I'd lost so much weight. They took me to the emergency room, and I begged for a feeding tube at that point. And they told me they couldn't because I was so depleted and so dehydrated, they would have to get me in better shape. So I said, I thanked him for that. We talked a little bit more. He said, would you like to see a picture of my family? I said, I'd love to see a picture of your family. So he showed me the first one. He tells me about one of the things that's been great. Now, he's now 9 years out after his treatment. He's had no recurrence of his disease. He was not a smoker, had no other risk factors. He just happened to have a tongue cancer. And he tells me about the wedding of his daughter, his pride and joy, who had just had it. They had a beachside wedding. And I said, can I ask you a favor? He says, what's that? I said, this is what nutrition and cancer is all about. I said, would you mind sending me those pictures? I said, I'd love to make you a part of my talk up at the Mayo Clinic. He was so touched by that he was going to make a difference for other people to see what was important. So we did that. We actually took a picture of the speaker in front of him and his family at the Mayo Clinic, and he was totally enthused about that. I think anything, whether we're talking about my woman with pancreatic cancer who got to see her son and who went back to work and had no recurrence of her disease, we have this young man who again is 9 years out, has no recurrence of his disease. We have to fight for our patients. We have to be the voice of our patients. And nutrition is one of those things that is interdisciplinary. It belongs to everybody in the tree. the team. But you guys are the experts. And you're the ones who really have to argue to make a difference so that all of your patients either have quality of life for the time that they have left or have quality of life for the rest of their lives. Thank you very much. Since we're a little behind, what they're supposed to do now.
Some coffee break.
Coffee break. Exactly. 15 minutes. We don't need the whole 15 minutes. You can have your bio break and go to the restroom. Where are the restrooms located? Tell them, not me. I don't want you to know. And then you're going to have plenty of time for questions later, but if there's a few that are really burning when they come back, you can have one or two